HUBWeek is a citywide festival, and it's designed to enhance Boston's reputation as a center of innovation, learning, medicine, technology, and the arts. And I'm Carrie Goldberg. I'm a health and science reporter at WBUR, which just ended its fundraising today, I have to tell you. Mass General Hospital joins Harvard University, MIT, and the Boston Globe as founding HUBWeek partners. And just on a personal note, I'd like to say that never have we needed an event like HUBWeek more than at a time when Googling Boston brings up a video of these two dudes saying, it's a baby whale, it's a sea turtle. Have you seen that? It went totally viral and it was so embarrassing. What is that thing? I prefer to think that HUBWeek is a much better reflection of my hometown, and it's certainly a reflection of the extraordinary range of medical research and innovation going on in Boston. You might know that Mass General Hospital is the largest private hospital recipient of NIH funding in the nation. And this afternoon's session with three clinician scientists who are presenting is a perfect example of the kind of cutting-edge research that's going on in Boston and the amount of collaboration happening across our hospitals, our universities, and industry. Now, just to get you particularly in the mood for this session, we have a little video. In the 1997 science fiction thriller Gattaca, parents would predetermine their children's lives by designing their genetic makeup. And in the Star Wars series, of course, Luke Skywalker uses a bionic hand after his own hand is lost in a battle. These are images that will be relevant to us today, you'll see. The basic idea is that what was once science fiction is now more and more medical innovation. And clinical investigators in Boston hospitals and universities are working together to deepen understanding and treatment of brain disorders, disease, and injury, and exploring big questions about what defines us as human beings, and working to end our pain, and they are working to make our lives better. So I'd like to introduce our three stellar panelists. I'm going to just introduce them all together, and then they will each come up and make a presentation separately, and then after that we'll have a discussion, questions and answers with all three of them. So our first panelist is Mass General Hospital's Jordan Smoller, MD, what is STD? PhD? PhD. And he's exploring the role of nature versus nurture in mental illness. And he wrote a book I really loved called The Other Side of Normal that I would highly recommend. Neurologist Leigh Hochberg, MD, is leading the development of technology that uses thought to control movement in patients with severe spinal cord injuries. So it's both really futuristic and also holds the promise of helping people who are in the very dire situation of being essentially locked in. Right? And third, Darin Dougherty, MD, is part of a team including researchers from Boston University Medical School, MIT, Harvard, and Draper Labs that's studying deep brain stimulation treatment of psychiatric illness, especially post-traumatic stress disorder. And just a personal note, I did a WBUR story on their work, and it was really hard to sound like an objective, slightly pompous NPR reporter, when really it was just blowing my mind. So all three will help us understand more about their extraordinary work, and we'll also ask them, and you can ask them, to make predictions about the future of neuroscience. And we'll also be joined in a few minutes by our host, Gerald Rosenbaum, MD, Chief of Psychiatry at Mass General. So, Jordan.
Thank you so much, Erin, and it's really exciting to be here, and that's the first time I've ever been in an action movie, so I'm really let me see if I can hook this up. So my goal is to tell you a little bit about research that we and others are doing to understand the role that essentially genes and experience play in our mental health and in mental illness. And I'll just say that one of the things that motivates many of us actually working in this field of psychiatric neuroscience and genetics is the enormous toll that psychiatric disorders and neuropsychiatric disorders take. So these are the leading causes of disability in this country and worldwide, actually outpacing cardiovascular disease, cancer, and so on. And they can be lethal. Suicide, as you know, is a leading cause of death in this country. So if we're going to really make progress in treating and perhaps preventing the suffering that's associated with disorders, you have to have a basic understanding of how they arise, what are they about, what's going on, and that's really what we're trying to untangle. So if you asked psychiatrists 50 years ago, what are the causes of mental illness, there actually was an answer at that point, and it was actually mostly the fault of one person, and that was the mother. And people may be familiar with this. It's astounding to look at these kinds of quotes, which were not fringe ideas. These were mainstream ideas, that autism, for example, was the result of mothers who were cold to their children and didn't want them to exist, or that schizophrenia was due to a mother's inability to love her child. These were misconceptions that caused an enormous burden of shame and guilt, and didn't advance our understanding very much. And it really, in many ways, was the advances in neuroscience and in genetics and a number of other areas that have allowed us to move past some of these things. So let me tell you, frame what I'm going to say in terms of something that's, of course, very familiar to us. We, here in Boston, suffered a terrible tragedy a couple of years ago with the Marathon bombing. And about a month or so, well, actually it must have been about 3 months after that, I was sitting in my office with a gentleman who'd been referred to me by his primary care doc. And he had been injured in one of the blasts and was now experiencing difficulty with nightmares and flashbacks, intrusive memories of this attack, difficulty sleeping, withdrawing from social contacts, and so on. The things that we would call symptoms of post-traumatic stress disorder. And so an important question is, how does that happen? What's going on there? And what can we do about it? And one of the things that may be surprising to you is that most of you have or will experience a traumatic event at some point in your lives, the kind of things that can leave scars, that can cause PTSD, post-traumatic stress disorder. About 70, maybe 80% of people will have an event like being in an accident or a natural disaster or suddenly losing somebody very close to them. A variety of pretty significant and traumatic events. That's the norm in a way. But it turns out that only about 1 in 10 of those will develop what we would consider to be a disorder, a post-traumatic disorder or PTSD. So the question is, why is that? What accounts for the vulnerability of some of us to the experiences that many of us encounter and in fact contribute to mental illness? So if we're thinking about nature and nurture, when you think about the nature side, one way to look at that is in terms of our genomes, our genetics. And I'm going to start by asking you a question. I want you to look at this list of conditions or diseases and think about which of these do you think is the most heritable? That is, where do genetic variations play the greatest role in determining risk in the population? So, well, let me start. How many people think it might be depression? Okay. How about Parkinson's disease? Autism? Breast cancer? Okay. So here's what the studies that have been done to estimate this heritability actually show. And what you see is that neuropsychiatric disorders are very highly heritable. This has been true for almost all of the disorders that we have studied, and in many cases, much more heritable. And heritable refers to the portion of risk that's attributable to our genetic differences than something like breast cancer even, or Parkinson's disease. That doesn't mean that, for example, 76% of an individual's ADHD is due to their genes. This is sort of a population measure, but it gives you a sense of how influential genetic differences are. And so, of course, in the last few years, this effort to actually find the genes that may be responsible for this has been moving very quickly. And sometimes actually people, I think, overestimate how quickly these things are moving, because we see a lot of press about it, and there's the sense that, you know, there's the gene for this and the gene for that, and this is my sort of favorite pet example, that, you know, when you're on the phone with somebody and they say, I'll let you go now, like they're doing you some kind of favor, but it's really them that wants to get off the phone and they just don't want to admit it. I think I've isolated the gene. Okay, that's not where we are. That's at least 5 years away. But here's the fact. The fact is that there has been kind of this, in the last few years, a kind of quiet revolution of findings that have accumulated. So if you ask people who are in the field in 2008, tell me a genetic variation that we know for sure is related to a psychiatric disorder, there really wasn't much to say at that point. And what's happened in the last few years is this incredible takeoff in genetic discovery. So we're now at about 200 across a range of different disorders. And this is, by the way, by no means the whole story. We now know that, in fact, one of the themes that has come out of this research is that many genes are involved. And many of those genes have just tiny effects by themselves that add up when you take them together to risk. So for example, just last summer, my colleagues and I, in something called, in a very large international consortium called the Psychiatric Genomics Consortium, reported a study of the genetics of schizophrenia. It was the largest of its kind. And they found 108 different genetic variations that were clearly associated with risk for schizophrenia. This one study. The figure you're looking at there, by the way, is a snapshot in one picture of the results of that study. So each of the little dots you see is a variant in the genome. And they're arrayed in order of their position in the genome. And the ones that are spiking up across that red line are findings that we consider really strongly associated with risk, statistically strongly. But there were 108, and in fact we think that there are thousands of variants that are contributing to risk for schizophrenia. And again, many of them have very small effects. Another theme that's emerged from this research is that has to do with how we even think about defining psychiatric disorders. As many of you probably know, in the field of mental health and psychiatry, we actually have a book, the DSM it's called, which gives you the criteria for different disorders. And in the latest edition of that book, there are more than 500 different labels for different varieties of disorder. But in the end, these diagnoses are really the result of people coming together, forming a consensus about symptoms and what criteria are involved. And it's sort of a consensus of experts. Now, we're starting to see from the genetic studies a slightly different story about how some of these things may or may not be related. How really different and distinct are they, at least at a genetic level? And so in the largest study of its kind, this is now a study that came out a couple of years ago, we were able to put together data for 5 very different psychiatric disorders and found specific genes, and those incomprehensible little labels there are individual genes that seem to have effects across these different disorders, across the diagnostic boundaries of things that, like autism and schizophrenia, we might think of as very distinct. So that's big news for psychiatry, because traditionally these are very, at least clinically, thought to be very different disorders. And in another report, we looked at this in a more aggregate way, and again found lots of evidence for overlap between the genetic basis of things like bipolar disorder, schizophrenia, depression, ADHD, and so on. So the DNA has not read the DSM, as we sometimes like to say. And we're finding these new connections. And one of the hopes is that this is going to move us towards being able to classify and understand these disorders in a way that's not simply based on symptom checklists, but based on some of the causes that are involved. The other big news is that these genetic studies are not simply coming up with a list of genes that may be involved, but that list, and through technologies that we now have, is beginning to coalesce into biological stories that tell us something about the fundamental pathways that contribute to these disorders. And many of these are really unexpected things, and that's exciting actually, because as you may know, essentially all of the approved treatments for that are medications for psychiatric disorders are based on biological insights that are 40, 50 years old. There has been arguably nothing fundamentally new. And that's because we were going on a limited set of ideas about what might be, maybe there's too much of a neurotransmitter or too little. We're now getting insights into totally different avenues for developing treatments that might be more effective. And one surprising result of some of these studies, for example, has been that genes involved in how something called calcium channels operate in the brain seem to confer risk for schizophrenia, bipolar disorder, and depression. And that led my colleagues here at MGH to a small study, but beginning to see, does this potentially have implications for therapy? So using a calcium channel blocker, this is a drug that we currently use to treat heart disease and blood pressure, found evidence of some benefit for depression in bipolar disorder. So that's kind of exciting. The other thing that genes do, though, is they sort of set us on a trajectory in life. We begin our lives with a kind of bias in the way we approach the environment. Each of us has we're starting out pointed in slightly different directions. And one example of this is the fact that some babies are very shy and inhibited in novel situations, and others are very bold and outgoing. And many are sort of in between, but those differences are observable as early as 4 months of age. And research that's been done here in our department and with colleagues at Harvard has shown that those kinds of temperamental differences are fairly stable, and in some cases can predict risk for things like anxiety disorders. And you can also see the effects in terms of brain structure and function later in life. So we've found that there are genetic variations that seem to contribute to these very slight differences in how we begin life approaching the environment. And by virtue of the genes that we inherit, some of us begin life with sort of looking at the world as the glass half full, and others may be more the glass half empty. And over time, that may set the stage for real differences in personality and development. We've got a very large-scale project going on here at Mass General called the Brain Genomic Superstruct Project, where we have used cutting-edge imaging technologies to look at brain structure and function, and also collected DNA, and begun to try to study what is the genetic and brain basis of differences in personality and differences in risk for things like depression or anxiety disorder. And just to give you an example of the kind of thing we see, we found in a sample of about 1,000 folks who had participated in this study, a region of thinning of the prefrontal cortex in the brain, which is important in modulating our emotions, that seemed to be associated with this kind of anxious, depressed temperament, social avoidance, but also interestingly with genetic loading for depression. And we got these from very large-scale genomic studies, suggesting that genetic loading for depression may have an effect on brain structure in ways that play out in our emotion regulation and our temperament and so on. Now, we know that there's a lot of other elements to this equation of how our lives turn out, what makes us vulnerable or resilient. So what about the nurture side of the equation? We know that genes are not destiny, and you can imagine, if you think about it for a minute, why that has to be the case, right? We evolved in a situation where we have a finite genome in an ever-changing world. So it would be impossible to pack all the if-then kind of instructions into the genome. As soon as you encountered something that you didn't have the if-then instructions for, you'd be in big trouble. And so the greatest, sort of most important gift that natural selection has given us is the ability to adapt to life, what we would call plasticity in the neural kind of sense. And we now know that experience, especially early experience, can have very long-lasting effects on not only our personalities and so on, but really at the level of how our brains wire up. I'll just say something about that. One thing is that we know that childhood adversity is a significant risk factor for a whole range of psychiatric disorders. So anything above 1 on that line, which pretty much everything you're seeing there, is strongly influenced by adverse events and childhood maltreatment and trauma that can happen early in life. And one question is, how does that work? It may work in part by the fact that as we pass through developmental windows in childhood, experience is shaping the way our brains develop. It is helping our brains tune into whatever the world is like. So the child's brain is kind of placing bets about what the world is like based on what it's been like. So if you're tuning into a world that is stable and nurturing and so on, that's one thing. Tuning into a world that is harsh and unpredictable, we're adapting even at a brain level to what that might be like and preparing and setting our thermostats for emotional reactivity to that. And just to give you an example of that, this is work from a psychologist, Seth Pollack, who was interested in how childhood maltreatment affects our social sense, how we look at it at each other. What he did was he had kids who had either been maltreated or who had not. And he showed them a series, this is one example of an experiment, but he showed them a series of faces that were morphing in their emotional expressions. So for example, from an angry face gradually morphing to a sad face. And he asked them to say, what emotional expression do you see throughout this whole period? And what he found essentially was that the kids who had not been abused stopped seeing anger in the face. This is probably hard for you to see, but very quickly they stopped seeing signs of anger. The kids who had been maltreated saw anger when there was just the faintest whiff of it in the expression. And there are other studies that corroborate this. The implication being they have tuned into a world where it's really important to be able to detect anger, to set the game high, because it might mean the difference between getting hit or getting away. And so they've developed a kind of sad expertise for seeing anger. And we recently did a study along these lines using something that we're very excited about, which is a web-based data collection platform, something called Test My Brain, which was developed by Laura Germain, who was a postdoc with me now. And this is and I encourage you to go to the site. It's actually a lot of fun, but it actually allows us to collect data on a very large scale. So she's collected data on almost 2 million people now in various cognitive and neuroscientific tasks. And we were asking the question, do we see this kind of thing, an effect of early adversity on social sense? And in fact, what we found in a fairly large sample was that childhood maltreatment seemed to almost relatively specifically affect the way how good people were at reading other people's feelings and thoughts in adulthood, which is a capacity that obviously affects a lot of what we do. But it's not just a matter of what happens, but when it happens. And so we've also been very interested in studying the concept of sensitive periods. That is, there are certain periods of development where what happens to you matters a lot more than others because it has a strong effect on the brain as the brain passes through a window of plasticity. So in another study that we've recently done, looking at about 14,000 adults, we found that there were these particular windows. So adversity happening and abuse happening at 3 to 5 years of age had a particularly profound effect. It wasn't simply that it was earlier or was worse, but there seemed to be a window in which it particularly was raising the risk of depression. The last thing I want to mention, though, is that we can also harness this plasticity for help, for improving what we do. And the example I want to give you here is in fear and fear-related disorders. So, for example, post-traumatic stress disorder, which we started with, and anxiety disorders, are in some ways the emotional fear learning system that we all have in our brains kind of gone awry. And the most effective treatment for those is something called cognitive behavioral therapy, where you're essentially you're undergoing emotional learning that helps you extinguish your fears. Learning that something you felt was dangerous is actually safe. So by understanding the biology of how we lay down those emotional memories, we learned that, and this has been known for some time, but there are a couple of key neurotransmitters that help nerve cells lay down these memories. Glutamate is one of them, and it requires a cofactor, a friend, named serine or glycine. And that led people to think that maybe we could actually sort of turbocharge therapy based on the fact that we might be able to modify how those nerve cells interact. There is a drug already on the market, the reasoning was, that actually mimics this serine, and it's called D-cycloserine, and it's actually developed as a tuberculosis drug. And now there have been a series of studies that have suggested that if you take this drug an hour before a therapy session for a variety of different anxiety-related disorders, it may speed up the emotional learning that's part of the healing process in PTSD or anxiety disorders, again, using the brain's own plasticity to actually boost the effect of what can be devastating anxiety. So to finally bring us back, the good news is that we do have treatments now that are very effective. And in fact, John B., who I mentioned, is doing much better. But our hope is that by understanding something very fundamental about the genetic contributions, when and where environment and experience play a role, we're going to be able to do a lot better, perhaps even prevent some of these outcomes. And I realize I'm perhaps running over, but I'll take 10 seconds to say what's next. So that was the last, what's been happening in the last 5 years up to today. What's next? Well, on the genomic side, we're in the midst of what you could consider a massive change in which the ability to gather genetic information, to sequence our genomes, has suddenly become feasible on a large scale. And we are now beginning to see, and we're involved in many of these studies, ways of integrating sequence and other data into our own medical care. And we use this to predict risk, to improve our outcomes. This is related to the whole concept of precision medicine. And in psychiatry, this is a big deal because, we're still operating on trial and error every time we sort of select a treatment. Could we use some of the information that we have, genomic, biomarker, other information, to really provide the best and safest treatment for an individual patient? So as you may know, there's a big investment from the federal government now about to launch this. We're very active in it here as well. Pharmaceutical companies and academia and our hospital and others are working very much on taking these genetic clues to devise better, more specific treatments. We've seen successes on that level in cancer therapies for sure, but there's a lot of activity now to, we're cracking some of the underlying biology. Can we translate that into new therapies? And could we even use some of these to understand what are the experiences or interventions that are going to be most effective to reduce risk and promote resilience? So there's a lot coming, and I'm going to end there and thank you all for listening.
Thank you, Jordan. Next, I'd like to introduce Leigh Hochberg.
It's a good moment to take a bite of your sandwich while we're doing more tests. very much, and thanks so much for joining us today. My name is Leigh Hochberg, and I'm going to be telling you a little bit about some advancing neurotechnologies that I, with a great team, had the privilege of working on the past few years here at Mass General and at some of our sister institutions both around town and also not too far from here. I am going to tell you about an ongoing pilot clinical trial of an investigational medical device, so it's important that I tell you my financial disclosures right up front. I'm actually hoping there's somebody here that can help me solve that problem. But it is quite important to point out that all of this research that we're hearing about today is supported through your public support through the National Institutes of Health, other federal agencies, and philanthropic support as well, for which we're all very grateful. The most important disclosure by far, though, as I mentioned, a great group of people who I get to work with every day, not only in neurology and in the clinical neurosciences, but really across a really multidisciplinary swath of science and medicine. So let me start off with a clinical vignette, as Jordan did in, I guess, 1996, only 20 years ago. There was a 42-year-old woman, who lived not too far from here, who was tending to her vegetable garden. She got a little bit dizzy. So she came inside and she sat on the couch next to her then 10-year-old son. She got a little bit more dizzy, and then suddenly she couldn't move the right side of her body, and then she couldn't move the left side of her body, and then she couldn't speak. She was treated at an outside hospital closer to where she lives. About 12 hours later, she was transferred here to MGH, and this was about the first year of a particular type of MRI that was being done, a sequence called diffusion-weighted imaging, and these are pictures of her brain at various levels. And I'm not going to turn you into neuroradiologists at the moment, but I will tell you that in this particular picture, gray is good and white is bad. Thankfully, most of her brain was gray, but there was one part, which we'll focus in on, that was bright white. That was the pons, a part of the brainstem right in the middle. And at that moment, what should happen was a small tear in an artery in the back of the neck, blood clot in another artery, leading to a stroke right in the middle of her brainstem, essentially disconnecting a perfectly working brain, thinking and aware, from an otherwise perfectly working body. When she was transferred, she was believed to be in a coma, that is unaware of anything. And then one of the junior neurology residents, who subsequently became one of my teachers, Nish Singhal, who's on the neurology service here, saw her in the emergency room and had the good thought to ask her to look up, and she did, and then to look down, and she did, indicating that she wasn't in a coma at all. She was awake and alert, and she could hear everything, and she could feel everything, but she couldn't move, and she couldn't speak. I'd ask you to think for just a moment about what it would be like to be in that condition. For people like her, and for other people whose neurologic injuries or illnesses may not be quite so dramatic, that we're hoping to develop a technology that will restore her ability to communicate and her ability to move. The story will get a little bit happier. There she is, and I'll come back and I'll tell you a little bit more about her in just a bit. The technologies that we and others in this field are developing are loosely called brain-computer interfaces or neural interfaces. And there's a list on the left there, including stroke, which happened to the woman I just mentioned, but lots of other injuries or illnesses that leave cognition largely intact, but prevent movement and sometimes also prevent communication. There's at least hundreds of thousands, if not millions of people affected worldwide, and the assistive technology that we can deploy today here at our sister institutions or anywhere else is really only modestly effective at best at improving somebody's recovery. In cartoon form, the desire to move, for example, starts somewhere up there in the brain, the part of the brain called the motor cortex I'll tell you more about, finds its way down through the brainstem, into the spinal cord, and we can think of any of these injuries or illnesses as a big red X, disconnecting again of the working brain from an otherwise working body. And there's a lot of great science going on here and elsewhere trying to repair right where that red X is, with pharmacotherapies, with cellular therapies. But there's at least one other approach, which is to try to get that signal back out of the brain and plug it back into where it initially was, which perhaps is the control over a computer cursor, or maybe the control over somebody's own limb, re-enabling this ability to turn thought back into action. So, brain-computer interfaces. I'll tell you about one type. You may hear about other types. But all of them, when you hear about them, have three major components: a neural sensor, a decoder, and an assistive technology. I'm a neurologist, so that's a person as far as I'm concerned. And if we think about a person who's unable to move but is wanting to move, we need to learn a few things in order to extract that intention, for example, to move one's arm. So some questions. What signal from the brain would we like to record? There's lots of different signals to choose from. What area or areas of the brain might be involved in controlling the voluntary movement of the hand? Turns out that there's at least a dozen. And ultimately, if we've answered those two questions, then we have to choose a sensor that's capable of recording that particular type of signal, whether it be electrical, magnetic, or anything else. And then we take that signal and we put it into the barely visible black box that's there. And that black box is the home of my good friends in computational neuroscience, who have one of the really fun jobs of the world, which is to be able to listen to the signals, to understand the signals in the brain, and to figure out what all of those signals mean. To understand, for example, what's up here is the firing rate vector, that is how fast is a single neuron firing away, and how do we interpret a whole bunch of neurons as they're firing and convert that in real time back into the movement of somebody's hand. So before we leave the bench in designing one of these brain-computer interfaces, we need to think a little bit about what we hope the device will do. For the woman we just introduced you to, or at least to her MRI, if we could restore her ability to type on a computer screen and browse the internet for education or entertainment, those would all likely be welcome improvements to her quality of life. For somebody with a cervical spinal cord injury, there's hope for improved control over wheelchairs or maybe even semi-autonomous robots that would help with activities of daily living. There was a Star Wars movie that we started with. I think it was Luke Skywalker's prosthetic limb that we were looking at. There are people who have been returning, particularly from our armed forces in Iraq and Afghanistan, who have lost limbs as a result of improvised explosive devices. And the prosthetic limbs that have been developed, both upper and lower extremity, over the past 5-10 years are really superb. But the controllers for those are actually kind of simple. One of the nicest prosthetic limbs that's available now is controlled by wiggling the foot. You put a few accelerometers in your left shoe, you wiggle it one way, and the prosthetic arm moves. Wouldn't it be better if you just thought about moving that prosthetic arm or maybe a robotic assisted device? The real dream for the research, though, at least for somebody with brainstem stroke or spinal cord injury, is to one day reconnect brain to limb using something called functional electrical stimulation that has taken these signals out of the brain, reconnecting them to stimulators in the arm, and allowing somebody to reach out and pick up that cup of coffee again. This is one of my colleagues from grad school. He and I actually spent a lot of time together, but the reason that he's up there is that he represents about a half century's worth of fundamental neuroscience, where happy, healthy animals were trained to sit in a chair, grab a joystick, play a video game, and then various scientists began to record from various parts of the brain to understand how the single activities of one neuron at a time might be related to voluntary limb movement. And every time the animal got that right, they got a little squirt of juice, so as long as you were a good monkey bartender, the animal would continue to work for hours and hours on end. And in about 2.5 hours, you usually have a fairly good sense of what one neuron is doing, at least in relation to voluntary limb movement. Well, we all have somewhere between 86 and 100 billion neurons, so learning how the brain works one neuron at a time is a little slow. So what really needed to happen was the development of some technology that would allow us to record from multiple neurons at once. And thankfully, Dick Norman at the University of Utah in about 1990 developed a nice little array of electrodes. There's one sitting on the head of a penny, so 4 by 4 millimeters, tiny, has 100 or 96 active electrodes that are sticking up from it, can be tapped in to the top of the brain, allowing either in the animal laboratory or more recently in our clinical trials, us to record from at least dozens, if not 100 or more individual neurons. Based on that, and I will now skip, with your permission, about 50 years of science. Please don't tell any of the people who either did it or taught it to me. We've now been able to take this array and we're beginning to listen and understand the neural activity of people with tetraplegia, that is, people who are unable to move their arms or legs, as they tried in our BrainGate clinical trial to control a cursor on a computer screen. So if everything's working, this is tapped into the brain, currently connected by some fine wires to a little titanium pedestal that sticks up from the top of the scalp. And if everything works the way that we want it to, one of our clinical trial participants will be sitting and controlling a cursor simply by thinking about the movement of their own hand. So as this happens, we make a small hole in the skull, we drop the array in, put a little piece of bone back, a little more titanium, put the skin back, and we're done. Are there any neurosurgeons here today? No, good, I can get away with that then. So, when all is done, today's state-of-the-art, soon to be improved, device in the brain, hardwired up to another device that sticks out, cable going back to some computers, allowing us to decode, we hope, this neural activity. So let me jump ahead, maybe a little brightly here, but you should be able to see, to our first participant in this study. We're now going back to 2006. There he is, 24 years old in that picture. When he was 21, he was breaking up a fight at a July 4th beach party, was stabbed in the back of the neck. Had what's known as a C4 Asia A spinal cord injury, was unable to move his arms or his legs since then. About 2.5 years later, he joined us in the trial, and you'll see him. You can maybe barely see his head right there, but you'll see and hopefully hear him as he's describing his control over the computer cursor.
Okay, so here's the phone and the desktop. What do you want to do first?
The sound can come up just a little bit. Okay, that'd be great. Thanks. So that was one of our research engineers kind of describing what he was doing. So although he's unable to use his hand, he's thinking about using his hand. We're decoding that neural activity, and he's controlling that computer cursor for control over what's essentially a simulated email. Thank you. So now you hear a participant talking, he's controlling this cursor just by thinking about it. And he's talking about it while he's controlling that cursor with the same subconscious activity, if you will, as I'm talking and waving aimlessly around this laser pointer. It's a very natural, the brain is good at this. It's good at controlling, at least this part of the brain, the motor cortex, is good at controlling an external device, which is our hands, our limbs, while we're thinking perhaps about something else. So here, because of this injury, he had been unable to control a cursor, had been unable to draw, so we wanted to try to restore that. You saw him try to draw his first circle, didn't quite work. That was his second circle where he saw the obstacle and was able to avoid it. And about 8 minutes later, we asked him to come back to try to draw the circle again.
Excellent. Now let's try
He's
going
able
back
to
to
do
the
fairly
desktop.
well. And anybody who's ever tried to draw a circle with a mouse, it's actually hard to get a fairly good circle. So not bad. I'll show you some other virtual devices, but here's a physical device. It's a real prosthetic limb, also made not too far from here by Liberating Technologies. Our participant right there is going to say, hopefully we'll hear him open and close, so we know what it is he's trying to do with that hand. And again, depending on the audio, we may hear his response to being able to do this.
Open.
So that's fun to see. But it's actually pretty simple control. It's what we would call barely one-dimensional control, or a state decode between one condition and another, open and close. We want to get a little bit better than that. Let me reintroduce you for a moment to the woman whose MRI you saw before. She enrolled in this trial about 9 years after she had that stroke. Device sitting in her motor cortex. She is unable to move her hand in a functional way. She's got a little bit of flexion in her arm. She's unable to speak still, even now, nearly 20 years later. But we're going to hear her try to open and close her hand in different ways, and we're going to be listening to one neuron as it's amplified through our system.
Close your hand.
So what you see are some waveforms of a few neurons. That sound
Open your hand.
is Mozart. That is the firing of a single neuron in motor cortex.
Relax.
And the moment she either tries to open her hand or relax or close her hand,
Close your hand.
we all can hear that that neuron is firing at different rates. So that is not the poorly tuned
Relax.
AM radio. That is the language of the nervous system. We can understand that, what that means. And that one's a simple one. But for the ones that aren't quite so pretty, which is the technical term for that neuron, the hopefully we can understand how the brain controls movement. And as you'll hear about from Darin in just a few minutes, how the brain is involved in control of lots of other aspects of our daily lives. So she enrolled in this trial, and we asked her what she'd want to say to other people with paralysis. So we presented her with this little QWERTY keyboard here. She now, unable to move her own hand, is pointing and clicking on this screen, and you may see the little standard white cursor there, and she is going to slowly set it out, but fairly accuracy, maybe with 1 or 2 errors in there. There's one. She's going to point and click to provide a message that I think is certainly optimistic. So here again, she's pretending that she's got her hand on a mouse. She's thinking about moving her hand left, right, backwards, and forwards. And eventually she's able to point and click to spell out a little wrap around this optimistic message of there is hope. To skip ahead a little bit, we've gotten better at this neural decoding. Here are 2 participants, though you can't see them. These are the 2 folks, Vikas Gilja and Chetan Darin, who helped to do this work. The 2 participants, both with ALS, both with limited use of their hand, with 1 or 2 of these arrays in the brain, are thinking about moving the little white cursor. They're able to get it now, as you might appreciate, much more quickly to the little target that's up there. That's part of the math. I showed only 1 equation, and I won't show any more. But as our math, if you will, our ability to decode the neural activity in real time from an ensemble of neurons improves, we get better and better at allowing somebody control over a computer cursor. And with that, I don't actually have control. So here's a different type of keyboard. This is a keyboard that actually is more appropriate for somebody who has great control over the cursor. It's called a radial keyboard. And you can see the 2 participants are actually now typing much more rapidly. They're able to type much longer sentences. There's a whole paragraph that one participant is typed. Again, these are 2 people with ALS who are quite rapidly pointing, clicking, and doing so quite stably. And here's yet another example of an even faster, perhaps, keyboard. The pointing and clicking. Here we've asked her to type. You must be the change you wish to see in the world. And you might be able to hear the clicking at each one. Again, be able to type ever faster, getting fairly close to the speed of average of at least 1 finger typer. Nowhere near yet the speed of a good typist with 2 hands and 5 fingers each is working, but getting much closer to something that I think would be of value from an assistive technology standpoint. Now let me reintroduce you to the woman who had that stroke years ago. Here, instead of virtual devices in a couple dimensions, we've asked her to try to reach out and grab these little targets that look like raspberry ice cream cones. And as she thinks about reaching out and moving her hand, that robotic limb is moving it out as she wills it in that direction. And there's another gentleman, also with a brainstem stroke, 65 years old, also with locked-in syndrome. We can't see him here, but he is controlling that prosthetic arm. This is actually the Deca prosthetic limb that's been approved for use, developed specifically to help people who lost a limb from traumatic injury. And again, slowly and not perfectly, but gaining some control over a standard 3D workspace of about the same space as either of them would be able to reach out and grab if they were sitting at a desk. So we asked her what she wanted to do with this technology, and she said that she wanted to take a drink. We said, okay. So we took this thermos, filled it with, for scientific precision, I'll tell you, a cinnamon latte. And you'll notice this is a properly branded thermos. Notice that even though the hand is there, which are the institutions, you can see on the bottom, it's an MGH there. And she's now grabbed it. She's got to bring it close to her. She's doing this, she's got to get it right in front of her because she doesn't still have the ability to rotate about her trunk, either backwards or forwards, or left or right. So she's going to take just a moment to get that thermos right in front of her. And when she does, she's going to pronate or tilt her hand, or the robot's hand, towards her to be able to get the straw into her mouth. So this is about 5 years into the study. the array that she had been in for a little over 5 years, 14 years after her stroke. And this 20, 30 seconds or so has nothing to do with neurotechnology, but it has everything to do with her still profound disability. She has a very limited power to be able to sip the latte, so it takes a little while to get the straw into just the right place. While she's doing that, I'll tell you this is one of our engineers who's under strict instruction to show no emotion. Move it around one more time. You can see that she was able to do that. I can assure you that's not the first time in 14 plus years that she's had something to drink. But it is the first time that she was able to do that solely of her own volition. So she's now going to return this thermos back to the table. Again, just by thinking about the use of her own hand, so you can see her response. She's happy, we're happy, that guy's fired. So, where's this going? What I've shown you so far is a device that's sticking up through the head. That is not a medical technology of the future, but it is the way that deep brain stimulators that we're going to hear about in just a little bit were first developed, the way cardiac pacemakers were developed with leads coming out of the chest. It allows us to do some things on the outside that we can't do when it's fully implanted, but we are well on our way to having a fully implanted system. We're working harder on developing interfaces for both improving communication, improving robotic and prosthetic limb control, and together with our colleagues in Cleveland, working on this dream to one day reconnect brain to limb, to take these signals out of the brain, route them back down to the arm, and let her or other people with tetraplegia reach out and pick up that cup of coffee again. We have a lot of work still left to do. I won't dwell on that at the moment, but I can assure you we are not there yet, but hopefully we're making some progress. And with that, I'll just highlight some of the team hard at work, and I think I will pause there. Thanks very much.
We thank you so much. And next and last, we'll hear from Darin Dougherty.
Great, while she's getting this ready, thanks for coming today, everybody. This HUBWeek is fantastic. There's so many great things to see, so we appreciate you taking the time to come to this event. So I'm the closer, as they say in baseball, and thank you so much. What I'm going to do is talk a little bit about some of the work I'm doing overlaps with what Dr. Hochberg is doing, but we're moving from the motor system into the cognitive and affective systems. And that's where I'm going to end, is trying to use this brain-computer interface to try to treat cognitive and psychiatric disorders. But what I'm going to do is just kind of march you through the history up to that point and then give you an idea as to where we are at this point. So first of all, disclosures. The little thing came off. I received research funding from Medtronic and Cyberonics. Those are really the only two that are relevant today. They're device companies. The others are pharmaceutical companies, which I won't talk about. And I received a small amount of honoraria from Medtronic. I train all the physicians in the United States on how to do deep brain stimulation programming for the treatment of obsessive compulsive disorder. So I get a small amount of money to fly around and do that. All right, so what is deep brain stimulation? This is what it looks like. Do I have a little pointer here? Yeah. Great. So what you have is you have a pacemaker-like device on the chest that's under the skin, and instead of the leads going to the heart, or sometimes now they even have leads go to the bladder for people that have bladder difficulties, the leads go under the wire goes under the skin to electrodes that are bolted to the skull, and then the electrode itself goes to a very specific target in all three dimensions within about a millimeter of where the neurosurgeon is trying to place it. And what it does is it delivers continuous stimulation through that electrode to the brain in order to affect function. This is the classic system. We call it open loop stimulation. I'm going to end with closed loop stimulation. The open loop stimulation is put it in, turn it on, leave it on, continuous stimulation. So open loop, continuous stimulation, it's been around since the 1980s for movement disorders. And currently it's used for Parkinson's disease, essential tremor, and dystonia. FDA approval for all of those indications in the neurology space. And over 100,000, in fact, I recently read 120,000 patients just in the United States have received This deep brain stimulation device has specific targets, the STN, which is the subthalamic nucleus, and the GPI, the globus pallidus interna. You don't need to have those memorized, I won't quiz you. But those are the targets for the movement disorders. And they're both areas in the basal ganglia that are involved in the motor function, like we just said. Well, over a decade later, we began to study using this open loop, continuous stimulation, deep brain stimulation for psychiatric illness. And these are 4 of the first 5 patients in the world who received deep brain stimulation at a target called the ventral capsule, ventral striatum. That's what the VCVS stands for. And this was for obsessive compulsive disorder. So what you can see, it's the same idea. You have the electrode come down, but it's going to a different target than one would move for movement disorders. We're going into circuits that we think will affect cognition and emotion. So DBS for OCD was first published in Lancet in 1999. And since then, multiple patients have undergone this treatment. These patients tend to be, in order to receive neurosurgery for a psychiatric indication, they need to have been ill for a long time, on average 22 years. And they typically have been treated with all conventional treatments without response before you would move on to neurosurgery. And note, we had about a 50-50 gender, but also note that about 90% of these patients with OCD, these are OCD patients, had comorbid depression. Just remember that. And this is what the data looked like. So we can see the Y box, the percent improvement. The Y box is the scale that we use to measure the severity of OCD. And what you can see, you can just look at all subjects rather than responders, but even all subjects at about a month, you have about a 25% improvement. At 3 months, you're at 40% improvement. Behavioral therapy and pharmacotherapy trials for OCD use 25 or 35% improvement to define response. So this cohort, who had received no benefit from all conventional treatments, were averaging response as a group. It's a very robust finding. And the other thing is, though, once they achieve response, it tends to be sustained going forward, which we don't always see with behavioral therapy and medications. So you can see even at 3 years, and we have data out farther now, they continue to do well. So because of this data, the FDA has now approved open loop deep brain stimulation for the first psychiatric illness in history. And it's approved for intractable OCD under what is called a humanitarian device exemption. The humanitarian device exemption is kind of the device equivalent of an orphan drug approval. Because less than 4,000 people a year are likely to receive this treatment, you don't have to do full pivotal trials. So they were able to approve it based on the open label data that I showed you. And then people are looking at other institutions at other targets that might be helpful for OCD. It may be that some patients respond to one target and some patients to other targets. So France, for example, has done some controlled and open label studies of the subthalamic nucleus that are underway. So you saw that 90% of those OCD patients had comorbid depression, and their depression improved while their OCD improved. We decided to do another trial after the OCD work where we took people with depression but not with OCD to see how they would do with deep brain stimulation at this same target, the VCVS or ventral capsule ventral striatum. As that says, we did an initial open label trial in the first 15 subjects in the world, 5 here at Mass General, 5 down at Brown, and 5 at the Cleveland Clinic. And here too, this curve probably looks very familiar to you. You can see now this is a depression score instead of an OCD score, but you see the same thing. Regardless of which scale you use, you see about a 35 to 40% improvement at 1 month, and then at 3 months you're at 50% improvement for the entire group. 50% here too for depression is used as a cutoff to define response or non-response to, say, a pharmaceutical trial. So these people are averaging response again. And same story, once they achieve response, it tends to be sustained. We were very excited about this. That was the continuous variable. As a categorical variable, 8 of the 15 subjects experienced at least a 50% reduction at 3 months, with 50% being defined as response. And 5 of 15, fully 1 out of 3 went into complete remission, meaning they had no depressive symptoms whatsoever at 3 months follow-up. So these were remarkable data. We were very excited. There are other targets, just as there is for OCD being studied. Another target is the subgenual cingulate, or area 25. And what's the best picture? Here it is. There's an electrode right here in the very ventral prefrontal cortex. Our target's about right here, so we're about 2 centimeters posterior. And this is work done by Helen Mayberg and colleagues, first at Toronto and then at Emory University. And their responses looked about the same. 4 and 6 patients. We had 8 of 15, and this is open label data again. Nucleus accumbens target is being studied. You can see where that target is. Just another place to put the electrode. This is being done in Germany at the University of Bonn. And here too, another target, but again, about the same open label response rate, about 50%. So all the data reviewed so far have been open label. And this data looks so exciting that the device companies decided to sponsor trials to get FDA approval. Now, depression is much more prevalent than OCD, so it can't be approved under this orphan device approval. It requires full pivotal trial. And so two trials were done. One is the ventral capsule, ventral striatal, which we just published a few months ago. And unfortunately, in the controlled trial, it failed to demonstrate efficacy. So it didn't work when we had an active versus sham treatment rather than just open label where everybody knows they're receiving treatment. And a comparable trial being done at the same time at Area 25, which I showed you earlier, was also closed because it was not going to reach its endpoint. So this is frustrating. On the one hand, we have open label approval for OCD, but it looks like we've kind of hit a dead end with open label, put the electrode in, turn it on and leave it on for depression. So the OCD is approved, both pivotal trials have failed of open loop DBS, and so what I want to conclude with is we think that some of these more complex disorders like depression, PTSD, that putting an electrode in and stimulating, while it might be effective for motor system disorders, we may need to do more complex stimulation technologies for these psychiatric disorders. And we move from open loop to closed loop. And really what closed loop means is you put the electrodes in and record from one area, and when a certain threshold of neuroactivity is detected, that's tightly coupled via statistical modeling. Leigh showed one equation. They get pretty complicated. It's tightly coupled to the symptoms, the neuronal activity. Then when that neural activity is reached, you know the symptoms are there, and you deliver stimulation in another area to mitigate the neurosignature in the symptom. So it's responsive and will only stimulate when that certain threshold is reached. And so that's really what we're working on now here at MGH. About 15 months ago, we received a $30 million grant over 5 years from the Department of Defense to develop these implantable closed-loop technologies for disorders that veterans are coming home with. Things like PTSD, depression, traumatic brain injury, substance abuse. And we call our project Transform DBS. And really, this is the idea, is we're going to take our clinical insight and expertise, having probably the busiest psychiatric neurosurgery service in the United States. We're going to do some imaging studies to see what areas are involved in different cognitive and emotional functions. We're going to model the neuronal data. Leigh showed the firing rate, crackle, crackle, crackle. We're collecting hundreds and thousands of neuronal data, and then we can model what each of those firings and different patterns of firings mean in terms of the subjective state of the person. And then we'll put our next generation hardware, the new deep brain stimulation device, in place. And we've developed that from scratch with our colleagues across the river at MIT. So overall, I'm just going to go over the workflow to give you an idea. We're 15 months into a 60-month project. Stay tuned. It'll be fun to watch. So one problem in psychiatry is rarely do people have disorders and that's all they have. Look at this, 10% of people with major depression have no comorbidity. The other 90% have other disorders like PTSD or substance abuse. And this is a real problem when you're trying to do a trial of deep brain stimulation for major depression. You've got a lot of compounds in there. So we decided to work around that by taking a transdiagnostic approach. And this solves two problems. First of all of the psychiatric disorders are constellations of symptoms. And they're probably, because each of those symptoms or behavioral domains has different circuitry that's involved in it, there's probably not a depression spot, because it's a constellation. There may be a spot for one of the behavioral domains that we're interested in, but probably not a depression spot or a PTSD spot. And so what we're doing is we've been meeting with the FDA, and we're going to move from outcomes of treating depression to treating these behavioral domains. So for example, approach and avoidance. Avoidance is holding up, kind of like the patient that Jordan told us about. Approach, hey, I need drugs. I'm going to drugs, I'm approaching the drugs. Substance abuse. And all of us on all of these, cognitive flexibility versus perseveration, just can't let something go. All of us are somewhere on these spectrums, but the normal is usually right around here at the intercept. And so we're ignoring diagnosis because you can see you can have patients with major depressive disorder, generalized anxiety disorder, and traumatic brain injury, completely different diagnoses, but they all don't be in the same place in terms of one domain, in this example, perseveration. Conversely, you can have people with the same diagnosis who are all over the place. You can have one person with depression who has emotion dysregulation, another is perseverative, another is avoidant. And so we are going to treat these behavioral domains and not worry about the letters inside these circles. And that's really the outcome measures that we're working with the FDA for this product. We're doing multi-mode neuroscience. We're doing brain imaging over at the Martino Center in Charlestown. It's the preeminent neuroimaging center in the world. It's where they invented fMRI, for example. We're also going to do human interoperative recording. When people are undergoing neurosurgery, we can put electrodes in the brain and measure them firing while awake, behaving human beings perform a task. We also have patients who are under epilepsy monitoring unit where they're having depth electrodes placed in their brain in order to map where their seizure is. And they'll have these put in place and go up to the epilepsy monitoring unit for a week or two. And when they're not having a seizure, they're sitting around, and we can wheel in our stuff and do tasks, assessing those behavioral domains and collect data from all of these neurons in the brain. It's a really unique opportunity. And then we're supplementing this with some primate and basic recordings as well. So here's the scanning. We're using fMRI. fMRI has great spatial resolution. We know the different areas that are activated, but the hemodynamic signal is about 2 to 3 seconds. That's a year compared to neuronal activity. The neurons fire in milliseconds. So we also are using a technique called MEG, magnetic encephalography, that can give us, it doesn't have quite the spatial resolution, but it has wonderful temporal resolution in the millisecond range. So we're taking the same patients and we're running them in both, and we can co-register the data so we have an idea of the where and the time course within individuals as we assess how they do on each of these behavioral domains. This is the interoperative work that we're doing. So patient stereotactic, we have electrodes in the brain. Here they're performing a task that becomes easy, moderate, and then even more difficult. And you can see the more difficult it becomes, just simplistically, there's more and more firing in the area of the brain that we're measuring at. So these are the kind of things that we can glean from interoperative recordings. And here's the epilepsy monitoring in patients. You can see these electrodes are deep in the brain with multiple contacts. So from each of these little dots, you can measure neuronal activity, what's going on. And they're throughout the brain in the medial temporal lobe, in the dorsal anterior cingulate, and we can also measure what's going on the brain surface as well. We can measure from all of these while they perform the behavioral domain task to see where they are. And now we've even moved to the point where while we can record from these, we can also stimulate from them. And now that we know what areas might be involved in the task as we run subject after subject, we're stimulating and see if we can change their behavior on these behavioral domains. And that's really the outcome. If we can, for example, help somebody on a fear extinction task with PTSD to normalize their fear extinction by stimulating in a certain brain area within the network, that's really the holy grail of what we're hoping to achieve. It's really kind of the affective equivalent of the motor control that Leigh showed. And then we're integrating all of this data. I guess that's all this slide shows us. And then there's a lot of math involved. We have to decode the signal. So we get all these spikes that you heard, crackle, crackle, crackle. And this is a mouse with traumatic brain injury, and he has to swim around, he or she has to swim around and find a platform so that they can stop swimming. And they're not doing too well, and here's what the spikes look like. And we can decode those spikes and see in their mind where their place receptive fields are. And then we can stimulate with the decoding algorithm and stimulate so that the firing rate is different. And we can direct them, and he finds very quickly the platform to chill out on. And he's like, oh, good, I don't have to swim anymore. So in summary, the closed loop sensing and stim are collecting all of this data, imaging data, firings from the EMU, interoperative data, And it involves a lot of math, and it's not, we have the neurocomputationalists in our team do this, certainly not my strong point. But they do all types of really high-end math, like deep learning via sparse autoencoders, identify the nodes that are involved, and then we know where within these networks of brain regions that underlie each of the behavioral domains, where to record from, when threshold is reached, where to stimulate from. And the idea is to move all of these people with different diagnoses on different axes of the behavioral domain to move them back towards the middle or the origin here by doing that. And that's really the overall goal of the Transform project. So right now, the one problem is we're doing these studies in the operating room or in the AMU where we record and stimulate. This is what we're using to do that. So we have to wheel this big thing in there into the OR. That's not going to fit in somebody's head. So part of what we had to do is work with our colleagues at Draper Labs over at MIT. And they've now successfully, it took them 1 year, but we have the device. They took this whole thing and put it in this thing that's 30 millimeters by 30 millimeters by 1.2 millimeters, 1.2 centimeters tall. And we now have a device, and we're actually putting it and connecting it to the monkeys, and actually being able to do the record and stimulation and then disconnect when we're done. It's a functional device. So we've achieved miniaturizing that. That's really one of the biggest things. So this will be able to be implanted in the skull and be for ambulatory patients. So what it looks like, there's a telemetry hub, that's what I just showed you. And it has a power source and a microchip basically. It does the computing and provides power. And then we have multiple satellites. And on each, it's modular. For each of these satellites, we can put recording electrodes and or stimulating electrodes depending on what that person needs. And also based on the imaging data, there's variability as to what areas are involved on an individual to individual basis. So in one person, this electrode, for example, might go here, and another person, it might go here. We can also anatomically vary where we put these modular electrodes. There's the satellite nodes, we call them. This will all be intracranial, under the skin. The electrodes themselves will be below the skull, and the telemetry hub, we're going to bevel into the skull and kind of sink it down, and it will be barely noticeable under the skin. So this whole device will fit in the skull. Electrodes, blah, 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 blah. All right, so our pathway to autonomous device is, we're doing open loop stimulation in year 1. Already have done this in both humans and non-human primates. We've moved now, and we're in year 2, we're at 15 months. And so we're doing the closed loop where we're actually recording, stimulating, and trying to move their behavior on these behavioral domains. Or our behavioral assays, really. They're assays of a function that will be our, just like getting a thyroid assay, see what your thyroid level is. These are the assays that we'll use. And then we're going to implant the hub in non-human primates, so put it in and leave it in to do these experiments. And we're going to do ex vivo studies. We're talking with, I was just at the FDA a few weeks ago, and we're putting the documents together. Well, what this will allow us to do will be to connect to human beings the ex vivo hub like we're doing in non-human primates, but with it not in the skull. So we'll be able to do the experiments for a while and then disconnect the hub and take it away. So it's called ex vivo instead of in vivo. And then we'll implant an entire system. So not when we first do the hub in primates, we'll use kind of the common electrodes we already use. Then we'll put the hub in, but also our custom electrodes in non-human primates in year 4. And we'll start piloting in human beings. And really the long-term goal is at the end of this 5 years, we're to have this device implanted in human beings. So we're only a few years from us being able to go forward with this. So with that, as you can imagine, this is a giant team. I think we have about 50 people on the team. Maan Eskandar, functional neurosurgeon, and myself are the co-principal investigators of the whole project. And then we have the regulatory group, decode group, that's the neurocomputationalist, the scan, data management, recording in the epilepsy monitoring unit, safety, the software. We have to put the code software algorithms into that microchip that detects the signal and then have a control algorithm and stimulate. And then our colleagues across the river doing the engineering side, they're the ones who miniaturized that rig into this tiny little thing. It's the Draper Lab team with lots of engineers over there. They've been brilliant and tremendous colleagues. So with that, I want to thank you for your time.
Thank you, Darin. Is Gerald Rosenbaum here? He is.
There he is.
I'd like to introduce
Okay.
the Chief of Psychiatry, Dr. Gerald Rosenbaum. Okay.
So I know you all probably have lots of questions for the speakers, and I'm just going to say just a few words and then let you get at them. But you've heard some remarkable stories. First thing I want to point out is you're at a hospital. So what you must already realize is this is no ordinary hospital. This is, Mass General Hospital is a hospital. Sick people come, they get taken care of. You've seen the shows on TV, people come here so they don't die. And yet, these remarkable advances are being discussed here by members of this hospital family. So, I want to say a word about that. Obviously, all of this happens for drops off trees. We do it for free. No, the reality is people come to this hospital because they want to be excellent in what they do. They want to take care of people at the highest level of expertise that's possible. But we all know, and this is implicit in what you've heard today, is that what we can do today, even if we do it very well, is not sufficient for many people. Is not at all sufficient for some, partially sufficient for others. There's a lot of work left to be done. So part of our mission at the hospital is to advance medical science and ultimately medical care. So this institution has created an institute we call the Mass General Research Institute. So we're not just a hospital, we're an extraordinary biomedical research institute. So how many of you here were aware that MGH is in fact the largest hospital-based biomedical research program in the country? How many people knew that? So a minority, but that is sometimes surprising to people who think of us as just a hospital. Some of that is, I think, is because of how our advances are represented in the media. Because all our faculty, all our doctors have Harvard appointments, when something wonderful in science happens, it's reported as Harvard. When one of our lab heads got the Nobel Prize, it's a Harvard scientist wins Nobel Prize, but he's right over there, he's in the Simkus building. Why is he called? So hopefully by forming this research institute and having its work widely known, that we'll be able to correct that impression. So the Mass General Research Institute has been created as kind of a front door for promoting our research enterprise, and it's a huge undertaking. There are more than 6,000 researchers working across more than 30 institutes, centers, and departments, and all are now united together in this at Mass General Research Institute. And just as you've heard today, remarkable scientific advances are happening every day, even though, and despite the fact that federal support for research has effectively been decreasing over the past several years. Competition for research grants is very intense. The scientists you hear from spend a lot of their time competing for decreasing funding. And the emphasis in funding has actually shifted from more basic and fundamental discoveries to more outcomes research, and yet we need to know so much more in order to improve our outcomes. So the MGH Research Institute is founded to promote, support, and guide our research enterprise and to help researchers with this vital work. The MGH has had research as part of its mission for more than 200 years. And I think it's why the treatment at MGH is sustained at such a high level, because we're always trying to push the envelope and make things better. So I hope you'll learn about that and as I am, be impressed about it. But a word about neuroscience, which is the focus of today's presentation. And the disorders that clinical neuroscientists treat, from PTSD to schizophrenia to paralysis, epilepsy, and so forth. These are daunting conditions to address. And there has been, as you can see from what you've heard today, amazing progress that's been linked to incredible new tools and technology. So the science is really exciting, and the promise of this scientific endeavor is really vast. Darin said, well, in 5 years we'll have an implant in a human. But the expected lag between all this exciting science to really broadly applicable new treatments for so many who suffer, I think still remains somewhere between uncertain and long. So I would say, though, not to be pessimistic, that we've already achieved something by where we are now, and that is these remarkable scientific advances have a current deliverable, and that is demystification. And we finally have a window to understand this amazing organ, which is the brain, and with that demystification and with that increasing understanding of how it works and how it does what it does in terms of helping us think, behave, feel, and so forth, that demystification is already creating a deliverable, and that's destigmatization. That the stigma for the disorders that are associated with brain illness and brain dysfunction are rapidly declining. We see that everywhere. And people who, one little anecdote, 43 years ago when I started training as a psychiatrist, and if I were in a social setting and someone said, "What did you do?" I said I was a neurologist. Because if I said I was a psychiatrist, people would move away. 43 years later, if I say I'm a psychiatrist, it's like, E.F. Hutton, everybody gathers around and wants to tell you something. They want to ask you something about a child, a parent, themselves. It really has changed. And so we welcome the fact that we all know that nobody's untouched by these things. Or as we say in our department, no family goes untouched. So with this demystification from these great scientists, even though wildly applicable treatments may be a longer time away, we have destigmatization, and with that comes an enormous promise for improved care, but currently hope and understanding. So thank you for being part of this. I'll turn it back to Carrie, let her take your questions for our remarkable panel.